Welcome to another edition of GasTalk, Somnia Anesthesia's series of podcasts on the smart approach to outsourced anesthesia services.
In this episode of GasTalk, we're joined by Dr. Clifford Gevirtz, an anesthesiologist who's been practicing for some 30 years. First at hospitals and now in ambulatory settings. He also happens to be the medical director for Somnia Anesthesia's ambulatory and office-based management services, and he's with us today to talk briefly about how anesthesiologists can help GI practices mitigate the revenue shortfalls that they're facing in the wake of reduced CMS reimbursements. So thanks for carving out some time to be with us today, Dr. Gevirtz. Can you share a little of your background with us?
Sure. Thanks for having me. I graduated medical school from Tulane, did my residency at the Albert Einstein College of Medicine affiliated hospitals, my fellowship at Mass General, and I've been practicing anesthesia for 30 years since then.
Wow. I would say you know your stuff. Can you share some insights then into how you see the relationship anesthesiologists and GI practices, or how that relationship is changing under these new CMS reimbursements, and how you will work with GI doctors for a smooth transition to this new paradigm?
I'd be happy to. I'll begin on background. The move towards value-based reimbursements, and by value we mean accessible, high-quality care and outcomes patients expect at low cost, is straining many GI practices that are already struggling with heavy caseloads. Under the new reimbursement schedule, CMS will be paying both gastroenterologists and anesthesiologists less for all the colonoscopies they are performing. When you think about it, what incentive is there to add more cases for lower reimbursements when you're already stretched to the limit? Some doctors might even decide it's not worth it to perform cases they're already performing and decide to scale back, which wouldn't be good for access because it would become a barrier to care for patients. When doctors think about the reporting requirements that accompany the new CMS schedule, the challenge for many smaller practices becomes even greater. So, how can anesthesiologists help? From the 60,000-foot viewpoint, we can say that we can help patients by increasing throughput. We can create efficiencies that ensure on-time starts and help lower cancellations. We can reduce the number of agents that we give to each of these patients. For example, using only propofol or only propofol and lidocaine, and not giving other fixed agents like Versed and fentanyl. We can use Heplocks without the IV bag, so no IV tubing, no 1,000 or 500 cc bags of lactated ringers or normal saline, which are in very short supply. We can also limit the pre-anesthesia workups by eliminating unnecessary laboratory testing. By doing all of these things, anesthesiologists work with gastroenterologists to keep things running smoothly in endoscopy units in whatever settings they're in. Hopefully, there will be no need to decrease the number of cases they perform. In fact, with more efficient operations, they just may be able to increase that number to make up for any shortfall resulting from the new patient schedules. In the end, I believe that it behooves providers to figure out where they fit in the new value model so that all stakeholders benefit from these and other changes.
Well, thanks for sharing all that information with our audience today, Dr. Gevirtz. I think it's something that the GI specialists can take to heart and find a little solace in. You're also giving some pointers to how great anesthesiologists work every day.
Thanks. Great to be here.
Thanks for listening to this edition of GasTalk. Check out somniainc.com/GasTalk for more information about outsourced anesthesia services or to listen to past episodes.